Hello. In this episode, we'll discuss the assessment of stable angina with focusing on the cardiac stress testing. I would like to dedicate this video series to a great cardiologist that I had the honor to be working with and supervised by in my affiliation with University of Louisville Hospitals, Dr. Paul Rogers, a great mentor who just passed away a couple weeks ago. The very first question is when a chest pain patient becomes a candidate for stress testing. Pay attention to the fact that this is different from indications of stress testing. We have a chest pain patient, most commonly visited in the emergency department. However, based on the risk assessment, he or she has become a candidate for stress testing. Before starting the discussion of stress testing, we need to know exactly what group of chest pain patients become the candidate for stress testing. For now, the simple answer is those in whom the coronary artery disease risk in 10 years belongs to the intermediate risk group or strata. However, to understand this concept, we need to go a couple steps before in the course of management of a chest pain patient. A chest pain patient who is visited in the emergency department is usually assessed regardless of whether or not he has symptoms of cardiac or non-cardiac chest pain, with the initial tests including ECG and cardiac troponins. Now, if the initial ECG and cardiac troponins are negative, we pay attention to the clinical pretest probability of cardiac type chest pain. If the patient has cardiac type chest pain with normal initial troponin and ECG, we still wait a couple hours, and given the stability of the patient, we repeat the ECG and cardiac troponins. If this patient at any step is not fulfilling the criteria for acute coronary syndrome, for early discharge from emergency department, we may consider using a scoring system called heart score. Heart score utilizes some findings such as historical nature of chest pain, E for EKG findings, A for age, R for risk factors of cardiovascular disease, and T for troponins. We'll discuss this score later on, but if the heart score has a value of 0 to 3 in a patient with negative initial assessment, including negative troponins and negative ECG, this chest pain patient, given the clinical scenario, would be a candidate to be discharged, and that's why we say heart score 0 to 3 with negative troponins means early emergency discharge. Again, pay attention to the fact that we are not discussing the acute coronary syndrome in this episode. But now that this patient is discharged and we are moving from the emergency workup to workup for the outpatient cases with chest pain or follow-up of the patient with chest pain, we utilize a scoring system that evaluates the 10-year risk of heart attack. That's different from 10-year risk of atherosclerotic coronary or cardiovascular disease, which is a primary prevention method for recommendation of statin therapy. Don't confuse it with this one. This is the scores like DF score, Diamond-Forster score, or Framingham risk score. These are the scores that evaluate 10-year risk of heart attack, coronary artery disease. That's why they are called coronary artery disease risk scores, not atherosclerotic cardiovascular disease risk scores. So let's start from this stage of the case management. We have a patient who did not meet the emergency management criteria for his chest pain, nor his chest pain was of non-cardiac origin. So this is referred to as unspecific chest pain. a very important category. The other possible case scenario is you have a patient who comes for a maintenance visit to your office, and he mentions that a couple months ago or a couple weeks ago he had a chest pain while being active, the typical presentation of stable angina. These stable patients are the examples of the situations or the unspecific chest pain patients in which we perform coronary artery disease risk assessment. Before initiating this stratification based on CAD risk scores, make sure you have a clear understanding of the use of atherosclerotic cardiovascular disease risk score. That's 10 years with the strata being less than 5% risk, 5 to 7.5% risk, and more than 7.5% risk in 10 years for atherosclerotic cardiovascular disease for recommendation for statin therapy. The other risk score that is used in non-ST elevation acute coronary syndrome is TME score that indicates need for early intervention. TME stands for thrombolysis in myocardial infarction. The third risk is the heart score that helps predict short-term MACE, major adverse cardiac event, in 1 to 2 months in patients with chest pain who have come to emergency department, and we need to know if they meet the criteria for early discharge or they needed to be admitted. Then we need to also know that there is a subset of patients who are just stable angina patients, or the patients with unspecific chest pain, and I'm not talking about non-cardiac chest pain, but unspecific chest pain. These group of patients require coronary artery disease or heart attack risk assessment based on their risk factors using the CAD risk scores. The most famous of them again are Diamond-Forrester, DF, or Framingham, but there are other risk assessment scores available, so you need to know the strata of low risk, intermediate risk, and high risk. If you are clear about this, now we are ready to start our discussion of coronary artery disease risk stratification and cardiac stress testing. So the next very important question is, how do we utilize the coronary artery disease risk assessment? Well, we use one of the available scores, such as Diamond-Forrester or Framingham or any one that is used in our institution, and the calculator gives us a probability. Based on the cutoff values, you may find 1090 or 2575 or 2080 strata, and I explain what do I mean. Some of these scores say the low risk are those who have less than 10%, and some say those are with risk less than 20% or less than 25%. Then the same one says the intermediate risk ones are the ones between 10 to 90%, and the high risk are more than 90% probability of coronary artery disease in 10 years. The other scoring system may say no, the low risk ones are the ones with less than 20%, intermediate ones are the ones between 20 to 80%, and the high risk are the ones more than 80%, and so forth, so on. So you have either 1090 or 2080 or 2575 as the percentiles for cutoff point of low, intermediate, or high risk of 10-year heart attack. The other way the cases could be presented to you is they just tell you the patient, based on the risk assessment, has intermediate or low or high risk of coronary artery disease. The most challenging way that you may be presented is to provide you with some risk factors and some symptoms and expect you to understand the concepts of low risk versus intermediate risk versus high risk. In that scenario that you are neither provided the exact results of the scoring systems nor the percentages, you need to know some very basic understanding of what is considered high risk, what is considered low risk, and most of the time, if something is in between, that's the intermediate risk, which is the focus of our discussion. So for example, the low risk patient is a patient who is currently asymptomatic plus has 0 cardiovascular disease or coronary artery disease risk factors. No hyperlipidemia, hypertension, diabetes, obesity with BMI more than 30, and many other indices that are used in these scores. For example, Diamond-Forrester score uses EKG changes, etc. Now, if the patient has currently no symptoms and he's considered stable in regard of his chest pain and has no risk factor, this patient is low risk, clinically assessing. If the patient currently has chest pain, or his chest pain is worsening or increasing in severity or happening at rest, what's that patient? That patient is actually an acute coronary syndrome. He might have come to your office and mentioning that, oh yeah, I'm gradually having more and more pain. I used to walk 3 blocks before my pain starts, but now I just go 1 block and I have pain, or last night the pain woke me up. These patients need to immediately be managed as acute coronary syndrome. So you categorize this as an unstable angina or any other types of MI, STEMI or non-STEMI, and you follow up with you follow the patients with the emergency management of acute coronary syndrome. However, you may have a patient who has stable angina, chest pain that happens on a set interval of activities, and this patient has some risk factors of coronary artery disease that I mentioned. BMI greater than 30, smoking, hypertension, hyperlipidemia, diabetes, first degree relative, etc., etc. Your calculator uses this, or you just know that the patient has risk factor and has had angina. This patient is intermediate risk. Again, why our focus is intermediate risk, the ones whose risk are calculated to be between 20 to 80%, or the ones that clinically have a stable angina and risk factor, because these are the patients who require cardiac stress testing for assessment of their chest pain. Now, remember that stress testing does not have just this indication, it has several other indications that I will mention, but I wanted to follow up our framework of thinking about chest pain, because there is a lot of complexities, and I have seen and I've heard confusing questions about this, and specifically the utilization of TIMI and heart score and Grace score and atherosclerotic cardiovascular disease risk score, the so-called pooled cohort, versus coronary artery disease risk score and Duke treadmill score. We will discuss all of them in an episode dedicated to coronary artery and cardiovascular disease risk scores. Now, an important question is, why don't we perform stress testing on the patients who had some stable chest pain episode and have no risk factor, or any patient who is anyway categorized in the low risk strata? The fact is, most of the stress testing results in these low risk patients are said to be false positive. The same way that if we have a high risk patient, such as unstable angina patient, and we perform stress testing on them, if the results comes negative in the high risk groups, that stress testing has no value and it is deemed to be false negative. So always remember, we interpret tests in medicine based on their clinical pretest probability. And a bridge to the statistics and epidemiology, please remember the pretest probability is either a clinical one or is a probability based on prevalence, though these two are the same but could have quite distinct applications. So just bear in mind, that's why we do not just randomly test anyone if they do not have the symptoms, or if, for example, we are not living in an area with high probability of certain conditions. Okay? Now, another question regarding stress testing is stress testing done by the primary care providers or requires cardiologic referral? Remember that primary providers can order stress testing, and in general, the rule that they follow is that if stress testing comes back positive, they refer the patients to cardiology, but if the results are negative, they resume the routine follow-up. Another framework is again, classifying the results of stress test into positive, intermediate, and low risk or negative. If it is positive, that means the patient needs revascularization and angiography as the next step. And this is just a very simplified framework. If the stress testing comes negative, the patient needs regular follow-up, and if it's intermediate, the patient just requires referral to the cardiologist. So be able to assess the next step based on whatever you are being provided. You may be provided with positive versus negative, or you may be provided with positive, intermediate result, or normal results. Now, before we start our precise approach with cardiac stress testing, I would like to read for you the list of general indications for stress testing. One indication is evaluation of exertional chest pain. Simply, stable angina. Patient has a stable angina. The nature of the pain is exactly angina, heart pain. You do not need to necessarily go through all that risk assessment. Primary providers may consider stress testing. The second scenario is what we have discussed so far. Patient comes for health maintenance to the office. Primary care provider evaluates the 10-year coronary artery disease risk and figures out that the patient falls into the intermediate category. It's quite okay to order stress testing for this patient. Another very important indication, still within the chest pain category, is the assessment of ischemic heart disease in patients with non-ST elevation acute coronary syndrome, non-STEMI, and unstable angina, whose TIMI score is low and therefore are not a candidate for early thrombolytic intervention. These patients, as well as the other patients who have high likelihood of a diagnosis of acute coronary syndrome, however, their ECG and cardiac troponins are normal, but again, the clinical picture is exactly an anginal chest pain. The patient has a chest pain that is associated with nausea and vomiting, radiates to the left side of the jaw or left arm, lasts around 20 minutes, is not very well responsive to rest or aspirin. So the historic features shout at us that it is an anginal pain. However, the ECG and cardiac troponins are negative. These patients, similar to the non-ST elevation ACS patients who have low TIMI score, undergo stress testing within the 72 hours of their discharge from emergency department. After this, we have some other indications for stress testing, including assessment of exercise capacity, exercise-induced pulmonary hypertension, or exercise-induced arrhythmia, as well as oxygen consumption, maximum oxygen consumption during exercise, for example, or any type of exercise-induced symptoms or exercise evaluation. So just remember, stable angina, patients with intermediate risk of coronary artery disease, those with non-ST elevation, acute coronary syndrome, whose ECG and troponins are atypical or negative or normal, or the TIMI score is low and don't meet the criteria for early intervention, and then assessment of exercise-induced symptoms, either pulmonary hypertension and arrhythmia, or exercise capacity and oxygen consumption. Finally, sometimes we use stress testing for assessment of certain valvular diseases. Okay, the most important question of this episode is the choice of stress testing. Understanding of the scenarios, indications, and contraindications requires the basic understanding of what is the stress and what is the testing used. So remember that we have different types of stress and different types of candidates who are eligible for one type or the other, or have contraindications for one type and another. And each one of these stresses are usually paired with a specific type of imaging modality. So the most basic and most commonly used one is the one that uses exercise on a treadmill as the stress and uses ECG as the imaging. So it is called exercise ECG test. However, if the patient cannot exercise, we need to use pharmacologic means of putting heart under stress, and that is when we use pharmacologic stress test and dobutamine as the stressors. So what are the examples of pharmacologic stressors in the stress test when the patient cannot exercise? They include adenosine or some of its similar compounds, such as regadenoson, dipyridamole, and dobutamine. Again, compound of adenosine, dipyridamole, or dobutamine. Now the question is, what is the imaging paired with these stressors? Remember, with dobutamine we pair echocardiography, but with the other ones, including dipyridamole or adenosine, regadenoson, and other adenozones, we use radionuclide myocardial perfusion imaging, or RMPI. Now, a bridge to the pharmacology to discuss the mechanism of action of these three drugs worth mentioning, because that will help us understand the indications and patient selection for each one of these methods. While stress through exercising produces metabolites that could dilate the coronary arteries, what is the mechanism that makes adenosine, dipyridamole, and dobutamine useful for stressors in stress testing? First, beginning with adenosine. Adenosine have several mechanisms of action. One of them is increasing cyclic adenosine monophosphate, and the other is increased conductance of potassium in AV node. Remember that increased cyclic adenosine monophosphate can function as a platelet inhibitor, and that is the mechanism we will discuss in the functionality of dipyridamole. But here it's believed that either increased potassium conductance or some other cyclic adenosine monophosphate dependent mechanisms, such as increased endothelial nitric oxide, would result in coronary arterial dilation. How about dipyridamole? Well, dipyridamole has exactly the same mechanism of action of adenosine when it comes to use in stress testing. However, remember, dipyridamole has other clinical uses, for example, secondary prevention of ischemic stroke, and that's because increased cyclic adenosine monophosphate in the platelets prevents platelet activation and aggregation. By the way, do you remember a drug that's exactly similar to dipyridamole and have the same mechanism of action for platelet inhibition? Yes, that is celestazole. Has exactly the same mechanism of action, but has a very specific use clinically, and that is for intermittent claudication. Okay, so we have these medications that cause arterial dilation, coronary artery dilation. How about dobutamine? Dobutamine poses a stress to the heart by its beta-1 agonist mechanism that increases heart rate and blood pressure, possibly blood pressure. So these are the methods of stressing the heart. Exercise, dilating the coronary artery, that is mimicking what happens after stressing the heart, or stressing the heart by increasing the heart rate as dobutamine does. Now, if you are asked which one of these mechanisms mainly increase the heart rate, remember directly that is dobutamine. Dobutamine does not necessarily increase blood pressure because it has some paradoxical effects on blood pressure, so we mainly see increased heart rate. However, exercise increases both heart rate and blood pressure. On the other side, adenosine and dipyridamole dilate coronary arteries, but they have no significant effect on heart rate and blood pressure. Based on this, if a patient is physically able to reach the target heart rate, which one of these stress methods are the best methods for him? Exercise, ECG. Now, if patient is not able to reach target heart rate through exertion, what are the stressors used? The pharmacologic stressors. And so that is one important contraindication to exercise testing. By the way, do you remember how do we calculate the target heart rate? Target heart rate is 85% of 220 minus age. So for example, for a 40-year-old patient, you calculate 85% of 220 minus 40, which is 85% of 180. And I just calculated, it's 153. So for a 40-year-old, the target heart rate for stress testing is 153 beats per minute. Now, we have yet another contraindication for the ECG stress testing or exercise ECG test, and that's when the ECG has certain abnormalities that makes it difficult to interpret for stress testing. What are those findings in ECG, in the baseline ECG of a patient, that makes exercise ECG test not a suitable choice? left bundle branch block, presence of pacemaker, any of the pre-excitation syndromes such as Wolff-Parkinson-White, as well as more than 1 millimeter ST and T changes. These make the interpretation of ECG in stress testing difficult. Remember, we actually look at ST and T changes as the response that we are trying to detect. So if we have already baseline ST-T changes, that will make it impossible to interpret the results. Now, if the patient is able to exercise but ECG is not interpretable, what is the recommended next step? We either move to our adenosine paired with radionuclide myocardial perfusion imaging or dobutamine echo. However, it's also possible to perform the modality that's referred to as stress imaging. That we still use the stress, the treadmill exercise, because the patient is able to reach the ideal target heart rate, but just the ECG cannot be interpreted. So we just switch to different modes of imaging. But let's say we are going to use our pharmacologic stress imaging tests. What are the best indications for them? Well, for dipyridamole or adenosine imaging with radionuclide MPI, the best indications are the patients who are not good candidates for ECG stress imaging, right? So, for example, the patients with left bundle branch block or pacemaker in their ECG making it difficult, and or the patients who cannot reach their target heart rates. These patients undergo pharmacologic stress imaging. Now, how do we choose between the dobutamine stress echo versus adenosine or dipyridamole / RMPI, radionuclide myocardial perfusion imaging? Let's call it nuclear imaging. Remember that we do not want to increase cyclic adenosine monophosphate in patients with reactive airway disease. Put it more clinically or simply, we do not want to use adenosine in those patients. Also, if the patient already is taking dipyridamole, for example, for secondary prevention of stroke, definitely that patient is not a good candidate for something that has the same mechanism as that of dipyridamole. The patient already has increased cyclic adenosine monophosphate in the patients who take dipyridamole. So for these patients, dobutamine stress echo is the preferred test. Now, what is the most important contraindication to dobutamine stress echo? That's presence of tachyarrhythmias. Remember, we mentioned that dobutamine, because of its beta-1 agonist activity, mainly increases the heart rate, right? So that's the major no-no for use of dobutamine.